Good morning. So, welcome to day 9. Now, see, one word of warning. This topic is such that literally, when we used to study, we feel that it is such a boring topic, right? That's pharmacology. Trust me, rest of the topics are like they are actually very interesting, but when it comes to pharmacology, we feel that why it is so boring. Why there are so many names. True. And today also, suddenly you will find that it would be like an explosion. There'll be so many names. And then it is expected that we are supposed to remember each and every name along with their side effects, along with how they act. But there is a very fine method to remember it. And what it is, actually, we'll be practicing it today. Once we complete our today's topic, right? First, we'll learn about this cardiac pharmacology. That is, we'll study that all the classes, class 1, class 2, class 3, class 4, right? All those things we'll study. We'll also be talking about first the basics, that is on what grounds these drugs will be working. Then we'll talk about some of the condition. Now see, as such, the cardiology is such a huge topic, right? There can be so many pathologies. It's like if you really want to learn cardiology, you have to spend about 10-12 days, right? Proper 10-12 days focusing only on cardiology. I'm not talking about anatomy. It is like I'm talking about only the conditions which are associated with cardiology, right? So in that, all arrhythmias, say tomorrow we'll be talking about myocardial infarction, but myocardial infarction is not the only thing, right? There can be so many other associated things. So what it's planning is, so when I was thinking about that, what shall we be doing in that second series? So it came in my mind that why don't we do it something like which will be integrated thing with physiology. There would be pathology, there would be pharmacology, and along with medicine, right? So this will be like an approach. What I really mean to say is that when we'll be talking about, let's say, body fluids, right? All those details of this, say, extracellular, intracellular fluids, how they really act, what happens in case if they go wrong, how will you really correct it with the help of various medicine, where the role of pharmacology is, and in which conditions actually you really see that. So it's not only that we'll be talking about cell, we'll also be talking about all those conditions associated with it. So that's how I have planned, and we are planning to start it from Monday, right? Monday to Friday. So that is like those 5 days. And in those 5 days, we can keep like 1.5 hour and 1 hour. So there'll be two lectures, right? We can keep a gap of half an hour or 1 hour. Let me know, right? Whatever is comfortable to you. But in this, my expectations would be that whatever we'll be doing on day 1, right? You must revise it very properly, very thoroughly when you come on day 2, right? Because over there in this series, there would be very less chance to repeat the things again and again. There would be very less chance. Otherwise, we won't be able to cover the whole thing, right? So take it like a commando training where every day you have to work very effectively, but you'll be very happy with yourself on the end of 5th day. There would be so many concepts. Now this, I'm not taking it like whether you are in first year or second year or third year, or even you are a very senior student, right? It's like a compilation of everything. That is what is called as the integrated training. That is what is asked into all these exams like USMLE, or even in our next exam. Okay, so today what we'll do is First, we'll be learning the pharmacology, like pharmacology, right? Seedha sada. Then at the end, I'll show you that what should you do. Take a piece of paper, big A4 size piece of paper, what you have to write on that, right? And then stick that paper in front of you in your room. And then every day, just whenever you are in front of that page, just have a glance at it. Just look at it. You don't have to really read each and every word. No, you don't have to read it. 72 hours, right? 3 days. So when we'll meet again on that day, let me know. Or you can put that thing into comments also. Or you can talk to me. This way, if you do, suddenly you will find that pharmacology is not as such so tough. You will be decreasing the load of cramming, right? So that is, yeah. Next has been implemented. Yes, it is in action. And I think if you are in first or second year, you will be the candidate for that national exit exam, right? It is like I have prepared a video on that. So when you get time, just have a look at it, right? Because that's where you will be competing with every student in India. They'll be in direct competition with you, right? Okay, let's start with our subject. And that's what we'll be discussing today, cardiac pharmacology. Now, before we enter into this, a very high speed concept, what is needed for understanding every drug associated, right? What I'm trying to say is that we'll not be discussing into very entering into very details of it, but these are the points which are needed. So that's how we'll be learning pharmacology. We are talking about heart. So in heart, we know that there are two types of tissues which we are interested in. One, those muscles, or which we call as the myocytes. And second, where we have given them the name, that is those pacers, right? Pacers. As said, they are pacemakers, but we have given the name pacers because like a marathon, pacer will be keeping that time, right? And everyone would be following these pacers. Myocytes, they simply follow pacers. So how these myocytes they were occurring, right? They were working like that there was a resting membrane potential, and then through that gap junction, right? Through that gap junction, calcium was peeping in. When the calcium was coming in, slowly and gradually it started becoming positive, and as soon as it crossed what is called as the threshold, right? Threshold voltage or the threshold potential, immediately large amount of sodium used to enter. This large amount of sodium that is coming in because of voltage gated sodium channels, right? Voltage gated sodium channels. Now what are these channels, what are these receptors, this that, all those things I'll be taking into that second series. So on the first day we'll be talking about all the receptors. Yes, literally we'll be discussing those receptors at length, so that it is crystal clear that it is not so that when the why it is happening, sometimes calcium is coming, sometimes sodium is coming, sometimes potassium is coming, right? What are they doing? And today there will be entry of one more thing, that would be the beta receptors. So you might feel, those who are seniors, those who have already learned the receptors, those who have got that idea, they'll say yes, this is fine. But actually there is a method to remember all those concepts. It makes entire subject very easy, right? So over here it is the large amount of sodium, voltage gated, that is at specific voltage those channels they click, and then all those channels they allow the sodium to enter in, becomes positive, it is fast, that's why this is a spike, and then sodium channels close. Once they close, this is what is called as the initial repolarization. Am I right? This is initial repolarization. And then over here, that potassium channels they open. Again, they are voltage gated because they are triggered at that high voltage. And in order to balance that electrolyte, it will start going out. As it is going out, right? At again, there is entry of calcium gated that is voltage operated calcium channels. So now calcium starts coming in. This calcium actually, when it comes in, it is balancing this potassium, right? So that's why this phase is also called as the plateau phase. This phase is plateau phase, but its importance is what? It is this phase where there would be contraction, right? Muscle contraction. So when the muscle is contracting, how it is contracting? In the cell, you know, there is sarcoplasmic reticulum, right? And in sarcoplasmic reticulum, it is like a storage. There are large amount of calcium in it, but this calcium is useless because it is packed. But this calcium which entered from outside, it triggered this and they released this calcium. When this calcium is released, this calcium is utilized by muscles for the contraction, right? And the muscle contract. Okay. Over here, when the repolarization starts, this calcium stops, right? This calcium stops. These calcium channels, they stop. But that potassium is still working, right? Potassium is constantly pumping, the potassium channel is pumping this potassium out. So it drops, right? All the way. And then the ion pumps, they come into picture, they balance everything, just putting whatever the calcium it is inside, it is put outside. Everything comes back to resting membrane and ready for the next phase. But you have to remember that this is the phase which is also called as the refractory phase. Refractory phase. So refractory phase, in which there are two phases, the initial phase which is called as the absolute phase. You do whatever that muscle, that myocyte is not going to respond. So that is called as the absolute phase. And the second phase, which is called as the sorry, which is called as the relative phase. In relative phase, if the impulse is strong, yes, muscle would contract. Then both the phases pass away, and then it is like normal routine activity, and the next cycle is ready to run. So this is what really happens in myocytes. There is a small change, and that change is when it comes to our pacers, right? When it comes to our pacers, that is pacemaker. In pacemaker, everything starts with that funny name, HCN. Hyperpolarized activated C nucleotide gated channels, right? So they are like, they allow that sodium to enter. Slowly and gradually, the moment resting membrane potential moves to this threshold one, right? Now this threshold potential is achieved. There are calcium channels, they open. These are the voltage operated calcium channels. Now there are two types of channels. These calcium channels, there are two types, L type and T type. Right? L type, they just, you can remember it that L type will be working later. And these T types, they are to start with. So they start with T type. So T type starts, and slowly and gradually when they work, that means they are activated and this calcium starts coming in. And then midway, this L type comes into picture and it is a spike. So in other words, even if you remember that it is just the calcium which enters into the cell, becomes positive, and then at its peak, T closes, L closes, and so that there is no influx of calcium. That's the potassium comes into picture. Potassium starts going out. That is the phase of repolarization. This first phase was depolarization. It goes all the way to resting membrane and it continues. There is no plateau, right? So that's the reason. Think it like these are our pacers. These are the stimulants. So they fire like this, right? So they just tell the muscle contract, and but that's it. So that's, they have to just pinch them. They have to just tell the muscle, okay, contract, and they come back, because they don't have to do anything. It is the muscle who is contracting and relaxing, contracting and relaxing. So that's the difference between both of them. Now remember, when we are using chemicals, right? These medicine, drugs, they are basically the chemicals. They will be acting on this entire system. They will be acting some chemical. It would come and will say that I don't like this calcium, right? Let's say these are the class 4 anti-arrhythmic drugs. So they say that I don't like this calcium. They will say that this calcium channel is my dushman. So for example, we are talking about verapamil, right? So which is a class 4 calcium inhibitor. Now think of, I'm just giving, we'll be discussing all these in detail, but just I'm giving example. Use your logic that entire system is going so well, but in this there is an entry of someone. Let's write it V, right? V is for verapamil, right? It's okay even if you right now don't remember the drug, but just it is one of the component which tells that I do have dushmani with calcium channels, so I won't let those calcium channels work, right? Now this drug, it cannot straight away say that yes, I'll stop all calcium channels. No, right? It will try to stop them. So let's say, take an example. If there are 100, right, as such, so they are in millions, but just let's say there are 100 calcium channels opening normally, right, in, let's say, 1 second. 100 calcium channels, they are opening in 1 second. Now with the entry of this verapamil, this speed is decreased. How much? 50 per second, right? 50 per second. So it means it has delayed that process. If it has delayed that process, how would it really affect? It would affect in this way. Let's see. Previously, though, in from over here to here, 100 channels they were opening. Now the speed has decreased. And this is our time, right? This is our timeline, and that's our voltage. So it makes a complete sense that everything is now slowed down. You know, it will slow down, and it will slow down in such a way that now the new graph would be something like, new graph would be something like this, right? I'm just drawing this much. Why like this? Because over here there are like 100 per second those channels were opening, but now it is only 50 per second. So it is taking more time, right? So the graph would be, here it was done in this much time, now it is taking this much time, double the time. So that's how every component would be working. They will be playing their role, right? Some will be acting on calcium, some will be acting on potassium, some will be acting on sodium, some will be acting on everyone. So when someone is acting on everyone, we use the word non-selective. These words will come very frequently. Non-selective means acting on all, right? And then when it comes to selective, that means we are dealing with very specific target. So target is specific. True? But this much is needed, and now we are straight away to the pharmac. Now see, as I said, that when we are learning any of the topic, it becomes quite easy to remember it because we are focusing on that topic. In exam, in Viva, because you are switching from one to, let's say you are asked some question, few questions. So then obviously examiner won't be asking you a question which is totally focused to one particular topic. It would be like you are asked first question from, say, cardiac pharmacology. Very next question might be from, let's say, renal system, diuretics, something you are getting asked. Or third, something like administration of the drug. Anything can be asked. So it's like you have to switch. The day you learn this switching of the brain very fast, and you will be the master if you can do that, right? It's exactly like you have watched one patient and then immediately second patient comes. So yes, you keep that thing aside and now you are focusing on second. You diagnose this and then you are watching the third patient. Slowly and gradually, your brain will start working it in such a systematic way because you are learning it in that way, right? So that's why I said never try to cram. Anything crammed, right, you are bound to forget. But if you understand it, it will become second part of your body, right? Second part of your brain. You'll close your eyes and things will start coming in front of you. Okay. So because of this, when we said that we'll be talking about anti-arrhythmic drugs, right? Which are the drugs which will help us in various types of arrhythmia, right? And yes, it is written in book like class 1, class 2, class 3, class 4, right? And sodium channel blockers and then beta blockers, this, that, everything. But theek hai, when we are learning, we remember. But then after some time, when it will start getting mixed with other drugs, it becomes a problem. Easiest method is what is called as the association. If you can associate right from the beginning, it will become so easy that how to remember it. So if you know 1, 2, 3, 4, right? But so you have learned the order. How? Anti-arrhythmic drugs, right? Anti-arrhythmic drugs. This. Okay. Write 1, 2, 3, and 4. Now, we also write 1 as alpha, right? 2 as beta. We write like that, right? So this is easy to follow. 1 is alpha, 2 is beta. And say 4 is what? Multiple of 2, right? 2 into 2, we normally say that. But this much is sufficient because first is you will write sodium like this, N alpha. So when we say sodium is like Na, right? So this we have changed it to alpha. Beta is beta only, right? Then 4, how do we write calcium? Ca plus 2. Now make this 2 big. So write it like calcium plus 2. So it is easy to say 2 2s are 4, right? So we never forget that the moment it comes like this 2, we know that it is 4. And the only thing which is left out is, you must have guessed, it is the potassium, right? So done. Class 1 is nothing but which will be acting on sodium channel blockers. When we say sodium channel blockers, it is not 100% block, because 100% block means systems will be dying. That's where the toxicity comes into picture, right? So when the toxicity comes into picture, if you give so much of those that all the channels are blocked, it means it's death. But we are like when the arrhythmia, when the heart is going at a very fast rate, 180, 200, 250, our purpose is to say that, come on, boss, slow down, right? Otherwise, you will fail. So how do we say? We'll say, okay, do one thing, block that calcium channel, right? So those 100 channels are firing, right? Tell them that only 25 would fire at one point. So immediately the whole process is slowed down and heart will slow down. When heart is slowing down, that means heart is now not demanding more oxygen. So it's the oxygen requirement, cardiac oxygen requirement will come down. So in that case, everything will start settling, right? So here it is, when we say channel blocker, it is not 100% block. It is like they will block some of them as per the dose. So that's why the dose comes into picture, because as we increase the dose, more and more channels would be blocked. So that's where you'll take the decision. So we'll draw it like sodium channel blockers. These are the beta blockers, right? We'll come to that, what is beta blocker. Third is potassium channel blocker, and fourth is calcium channel blocker. So easy. And there is one different class which is like miscellaneous. Who is not fitting in any of them is like miscellaneous. No doubt in miscellaneous, there are some good medicine to know about. One of them very good, very important is digoxin. So it's like, see, I injected 2 medicines in your brain, right? One was verapamil and second was digoxin, right? Verapamil was what? Verapamil was, if you remember, it was class 4. right? Class 4. So I used to write verapamil like this. Verapamil. Because when you write it like so, this tells ki yes, it is class 4, right? Class 4. Class 4, we write 4 like this, right? So this is verapamil is class 4. So actually, when you write it on a piece of paper, later on we'll see. So you can really make it bold. You can make it with different color, right? So that it gives you a visual impression. So even when you write verapamil, every time you'll write, you'll immediately say this is class 4, right? And when it is class 4, you'll say that it is a calcium channel blocker. And then we'll be going into the detail that these calcium channel blockers, they are of two types, right? One type which is used for hypertension and the second type which is used for this cardiac arrhythmias. So thus parallelly you are learning even other things. The advantage would be that you are not sticking to one topic. You are going on so many topics. So this is what is giving you a very nice coordination, right? Okay. So back to this. Yeah, we completed this. And a very, very brief discussion about arrhythmia. What are that? Arrhythmias. We are now so comfortable with SA node to AV node to bundle of His, and then these are the Purkinje fibers, right? This is on the left side. Yeah, there is, we know that there are more muscles over here. Here there are less muscles. Everything is good to you. And all these are SA node, AV node, bundle of His, Purkinje fibers. These are like plan A, plan B, plan C, plan D, right? And as you go from SA node to Purkinje fibers, actually these runners, they are now slow runners. Best runner is SA node. He's the best runner, best pacer. So he resets everyone. The day SA node is not there, AV node will take over that function. And then AV node takes over, right? But it is at a slower pace. But you know, in running, right? In running, if you have seen that, say when we were running that Tata Mumbai marathon, yes, we all, right, a big group, right? We run at our own pace because the time given is like 5 hours, 6 hours. You have to finish those 42 kilometers, right? It is so, we are sweating, you need nutrition. But then as you are onto that whirly ceiling, right? And then you see those runners, those elite runners from Kenya, Ethiopia, right? The speed at which they run, that is so good. And when you see them running, you stop running. You also stand and you start watching them, that at what pace they are running, right? But they are exceptional. You don't run with them every day. They are so good. They are the elite runners. They are the best runners of the world. Means they finish the full marathon in just over 2 hours, right? That's what their speed is. God knows what they eat, right? But they are so good. But still, it's a pleasure to watch. But when you watch them, you forget running. Same thing happens when suddenly our heart, right? All these our pacers, our routine pacers, SA node, AV node, bundle of His, Purkinje fibers, right? They are like running, and then that elite runner comes from somewhere. And when that elite runner comes, he takes over the entire heart. And in real race also it happens that sometimes you feel like, chalo, these elite runners, right? That's a track. They are given this different track and you are running in group over there. Well, I attempted once, right? I attempted once that the speed at which they are running, let's try to run at that pace. Well, you should not, because they are seasoned, they are Olympic players, right? For few meters, few 100 meters, it's okay, you can, but then you have to slow down. Same thing happens over here. Same thing happens. That when these super runners, they come into picture, right? SA node, AV node, all of them, they forget about their style and they are taken over by these elite runners. Now, these are very fast. and that is when the abnormal path is taken. It means beyond your normal routine, you are following them. That is what happens, and that is arrhythmias. Because if we try to run at this pace, right, definitely will not be able to finish the race because we are not trained for that high speed. But this is arrhythmia. When SA node, he said that boss, you have to beat at an average of 72. And suddenly this elite runner comes and says, "Okay, come on, let's run at 200." The whole heart runs at 200, then this heart is going to die, right? This is abnormal path. Why it can happen? One, abnormal automaticity. Automaticity is one of the characteristic when the heart beats by its own pace, right? No motivation is needed, self-motivated. But then suddenly some new unknown boss pops in. He says, okay, now I'll be the pacer. And he runs at 200. Heartbeat straight away goes for atrial fibrillation, flutter, right? Heart goes at the speed of 200, 200 plus. That's why see the word flutter, right? This is the normal beat, and flutter is this is what is happening in flutter, like this, right? So obviously you'll know that when it is beating like this, it is pushing large amount of blood, but when it is fluttering, actually that much blood is not getting pumped because it is just in 1 second, right? When you say the beat of 180, that means in 1 second heart is beating 3 times, so fast, right? And then that is one method. Second, abnormal re-entry. Abnormal re-entry. So that's heart, right? That's heart. And this poor heart, somewhere, let's say in the left ventricle, there was some infarction. And it led to death of this muscle, right? This muscle has died. Now this is like scar. So when the tissues, when the heart is completely fine, to those waves, they will be going straight away. But then over here, because it is a scar, right, they will go round and round, round and round. So this scar would be acting like abnormal re-entry because say current won't be passing through it. It's a dead tissue. So it will revolve around that scar. So it means this particular muscle, this particular portion, which is fine, but then it is getting again and again and again pinched by that current, right, which is revolving. So it will keep on firing, and that's what is called as the abnormal re-entry. This is abnormal re-entry. This is abnormal automaticity when there are few conditions. We'll talk about those conditions also. When some tissue suddenly feels, no, I am the boss, right? I'll not behave the way SA node tells. I am the boss, and this new boss pops in. So that is abnormal automaticity. This is abnormal re-entry, maybe post-MI scar, or when there are some accessory path which are created. These are the extra paths which are created, abnormal, right? In such case, say for example, bundle of Kent, it will come. So these are the three basic mechanisms by which the heart can enter into what's called as the arrhythmia, right? Out of sheer excitement, now heart is going on to that arrhythmia. So abnormal path taken. Okay, so this is what I was telling you how to remember, right? As we said, we wrote it alpha over here. So 1 is alpha, that means it is the sodium channel blocker. This is beta receptor, right? It is the beta receptor. Third is potassium, and fourth is Ca++, that is +2. Right, so that is fourth, and these are some specials. A special is miscellaneous, but I usually don't write miscellaneous because when we write miscellaneous, so it decreases the importance. So I usually avoid in my notes writing miscellaneous because it decreases the importance. When you write specials, so then right from this point, right, you try to reach to that special one. So you feel that, yes, let me finish first class 1, class 2, class 3, class 4, because there is a sort of reward in the form of specials. So that's where we'll be learning those special drugs, right? So it it makes me happy. So I always write it as specials. Okay, but as such, in the classification, it would be written as miscellaneous, but we'll consider it specials. Okay. So here is our first class, right? That's our, sorry. Uh, yeah, okay. So that's our class 1. Class 1, and see, as you have understood that entire graph properly, how easy it becomes. So this class 1, it is by nature, it is, sodium channel blocker, but it blocks potassium also. See, it blocks potassium also. So in such cases, there is a speciality about this class A, or the class 1. Its speciality is that they are called as the state dependent. When we say state dependent, it means they see that what is the state of the body. How is it? Selective. That means wherever there is need, they will go and work over there. That is, they are effective on the pathological site. Wherever there is trouble, right? Go over there and act. And if the condition is bad, they are more effective, right? So they are effective and selective. So we'll remember it like they are effective and selective. So that's what is called as the state dependent. Okay, now first let's see the graph, what it would do. This is sure just by looks at it, you know that we are dealing with the myocytes, that is our normal runners, right? We'll talk about pacers later. And what our runners are doing that it is in the state of this depolarization. It was the sodium which was coming in, voltage operated sodium channels. Now if we slow them down, right, immediately the class 1 drug would say slow down. So these sodium channels, they will not open in that bulk the way they should open. So they'll open slowly. So this peak is achieved slow. Okay, then fine, it would be achieved, and then it would like that potassium channels are also getting blocked. So then the entire graph would be extended. So over here, just look at this way, from here to here, the whole thing is slowed down. That's what we want, that the heart was shooting at such high rate. By giving this sodium, it will say, okay, sodiums go slow, potassiums go slow. So when the sodiums, they are going slow, it means that depolarization part will be slowed down. When the potassiums will be told to go slow, it will be the stage 1, 2 and 3. That means initial repolarization, plateau, and the later repolarization, everything would be slowed down. So everything is getting calm, right? That's the way to talk with heart. Okay, no need to listen to those ghazals, right, to slow it down. Okay, how it will reflect on the ECG. In ECG, remember the ECG, how the wave was getting formed. That was like P wave, then QRS complex, and the T wave, and it was like that, you know. So we need to know first thing, that class 1 is acting where? This is a new thing, because we said that class 1 would be acting on sodium, that is primary. It will be acting on potassium also, yes, but where? It will be acting on atria, ventricles and Purkinje fibers. It means if we have raised this topic, that means very sure that soon there will be few drugs which I'll be telling, no, they'll be acting only on ventricles, they'll not be acting on atria. Yes, that's where you'll be more and more specific, because tomorrow when you'll be discussing myocardial infarction, at that point we'll say that yes, watch the ECG, right? You know that there is ST elevation. ST elevation is into which leads. That will give you the idea that which part of the heart is affected. Which part of the heart? Only the ventricles are affected. So we need to do something for ventricles. Atrias are fine. So why are you slowing it down, right? Don't let them be fine. The problem is where? And when you'll be going into more details, then it would be like then the tachycardia, when the heart goes very fast. So then there is something which is very fatal, ventricular tachycardia, right? So in that case, you'll be becoming more and more specific. It is at that point when these drugs will be making a precise sense. Okay, yes, this is what really happens. So as we'll be studying more and more, trust me, these drugs, they will be coming back with many new points. Today, we could have done it like, okay, chalo, let's discuss class 1 in, out, everything in tremendous depth. But then what would be like? It would be like I'm dumping that information in front of you, but actual use, nothing. What's the point if I say that yes, this would be used in paroxysmal ventricular tachycardia? ठीक है, it is okay. Means you'll say क्या new word, but is it making any sense? No, subject to till you learn that point. And when we'll be learning paroxysmal ventricular tachycardia, at that point when we say, okay, now tell me which drug will act, you yourself would say, yes, that's how they will work, right? So that's how everything will. Now see, because you have learned ECG, I do have right to ask that PQRST complex, right? What was that QRS complex, right? What was it? You'll immediately say that it was something which was related to ventricular depolarization. Now, because we are slowing down the depolarization, yes, precisely. So obviously there would be long QRS complex, right? The QRS complex, which was initially like this, now that QRS complex would be long. Sure, because potassium channels, they are going slow, so that contraction itself would be slowed down. It is so good. Similarly, QT segment would be extended. Yes, because see, even the repolarization is getting slowed down as it is acting on sodium and potassium both. True. So even the contraction is slowing down, relaxation is slowing down. So contraction is slowing down, relaxation is slowing down. Result, slower heart rate. That was our target. True. Done. So that's class 1, which is sodium channel blocker. Now, all you need to do is just know about certain drugs. A word of caution, right? Class 1. Now, this is caution is okay. You are smart enough to know about it. You should not be giving it in case of heart failure patients, right? When the heart is already weak. Obviously, heart is weak, and then on top of it, you say, okay, Baba, go still slower, right? In that case, obviously, the pumping mechanism, the push itself would be slow, so much less, and that would lead to hypotension, decreased blood pressure, right? Because blood pressure depends upon the ejection force, that at what speed, right, the heart is really throwing the blood out of the aorta. So when the whole heart is slowed down, yes, it would lead to hypotension. So just logical thing. Okay, so now we have got something extra, and that extra is that class 1, so we wrote, what is this A? It means there are 3 classes, class A, class B, class C, right? So we do have class 1A, 1B, 1C. Nothing to worry about. In fact, it is very easy. 1, 2, and 3. This 3 is very powerful. 1 is number 2. So I'll put 3 ticks here. I'll put 2 ticks here. And this 2 is actually 1. Right? It is weakest. Why these 3? Well, it's an advantage, no? Use it as per need. So here it is. In 1A, that's where we have put 2 arrows up. So this is moderate, not the strongest, not the weakest. Quinidine, right? Quinidine, which leads to, its side effect can lead to synchronism. That means tinnitus, right? Whistles in the ear, vision is blurred, and the headache. So that's the head, right? That's the vision. These are the ears. So just it is this area which is affected, right? So when you think about it, when the queen is in your mind, obviously this much area would be affected. So that is the side effect. The second one, procainamide, right? These are the medicine names, procainamide. This WPW, SLE, right? WPW, I have just written WPW, Wolf Parkinson White syndrome. It's okay. We'll talk about it. But yes, it is used for that purpose. So right now, even if it is completely fine if you ignore all these facts, right? It can lead to SLE, systemic lupus erythematosus. Just remember that there is a name, procainamide. Then this is diisopyramid, right? This is diisopyramid. And this diisopyramid, let's say pyramids, they are in Egypt. They are in Egypt, right? And you need to take proper care because over there everything is like desert, right? So you will be having, say, dry mouth. If the sufficient water is not there, to dry mouth, right? Then ears, those eyes are dry. That means because there is no tears. So that means no lacrimation, right? So no tears, no lacrimation. Then urinary retention because there is no facility. And all these things, they are leading to hypotension, decreased blood pressure. Collectively, they are called as anticholinergic effects. What is this cholinergic, anticholinergic, etc.? In that series too, this is all these mysteries would be solved. A very systematic way, all the receptors will be discussing. But over here, just remember that in class 1A, we are dealing with one queen and one pyramid, right? So when queen comes, it is like ears, vision and headache, right? That's what comes. And when it comes to pyramid, that means it is like we are dealing with every dryness, right? Eyes are dry, mouth is dry, can't go for that urination, and the blood pressure is going to drop because no water, right? Use SVT. I've just written SVT, supraventricular tachycardia, right? And ventricular tachycardia. But that's okay. That's where we just remember this tachycardia. It means that rate, when the rate is exceedingly high, at that point, these things will come into picture. Now, when it comes inotropic, right? Inotropic, frequently you'll come across these words. Inotropic. Inotropic means they increase the strength, right? They increase the strength. Now, so this is negative inotropic. It is decreasing the strength. It is telling the heart, boss, relax, relax, right? Don't run. And that's what it will lead to hypotension. Hypotension. So moving on to class 1B. This is also sodium channel blocker. But over here, remember, that's what we talked about. Effectiveness. C, right? That was most powerful. Then the number was A, and then the number was B. So we wrote it like this, then this, and this, right? So C is most powerful, A is second number, B is the last, the moderate. So that's the thing. So class 1, we have, say, see, this is the difference. We saw that class A was acting on everyone, but suddenly that's the point which we need to remember. It is not acting on atrium. It is acting on ventricles and it is acting on only Purkinje fibers. So this is, okay, you can't, it is overlapping. Just a minute. Now it is okay. See, it is not acting on atrium. It is acting only on ventricles and it is acting on Purkinje fibers, right? So that's the point. We need to remember this. Say over here, Though A and B, they are so close, right? This class B is not acting on A, right? All right. The name maxillatin and lidocaine. This lidocaine is very popular, right? Because lidocaine would be used for, it can be used for digoxin toxicity. See, digoxin toxicity. You remember digoxin we talked about? Digoxin was what? Digoxin was, we said that during our specials, right? We said there is one very special and that is digoxin, right? So it means for that special drug, if there is any toxicity, it is lidocaine which will be coming as a rescue, right? And it is a local anesthetic also. So many times you will see the use of it. And in clinics, the moment you will see that lidocaine is used, it will strike that bell that yes, it is the class B, class 1B. As it is affecting the local, it is acting as local anesthetic also. More is given, CNS toxicity. Makes sense. This maxillating is where you will remember it like M4, right? I used to write maxillating like this. M is for McDonald's. So when you go over there, if you eat more, in right, obviously next day there would be GI symptoms, nausea, vomiting, diarrhea, all those, right? Because you eat unlimited, so that's what really happens, right? So the adverse effects, they are mostly GI symptoms. So what they do, they act on depolarized cells and ischemia affected myocytes. So that's so good. See, it is acting on ischemia affected myocytes, but those ischemia affected myocytes which are in ventricles. So now you are becoming so specific. Ventricles, ischemia affected myocytes, and when on ECG you see that okay, ventricles are affected, yes, call these drugs, right? They are needed. And thus they are used in the treatment of ischemic arrhythmia. That means post MI. Heart attack has come and now patient is lying and now you are supposed to treat that, right? Post MI. That's where you will, because see, post MI it happens. There are all the chances of this arrhythmia because of those ischemic areas, right? Suddenly there would be re-entry and then the heart goes on the fly. This is where it is important, right? That's how you'll be fitting. It is like a jigsaw puzzle, right? You are fitting all the puzzles, every piece together. No wonder ECG is long QRS and not long QT, just the long QRS, right? Because it is acting only on sodium, right? It is not acting on potassium. So it is not acting on potassium. That means that repolarization would be normal. It is not telling that potassiums you slow down. It is telling sodiums you slow down. When sodiums are slowing down, yes, the contraction part is fine. But then potassium, so they are going normal. So that repolarization part will be automatic as per the normal. That's why, see, no long QT, only long QRS. And here comes the third one, right? He is so powerful, right? Class C, very powerful. And it is acting everywhere. So thus it gives us the idea that A and B, alphabetically they are close, so close. But when it comes to class 1B, right, it is doing partiality with A. That means it is not acting on atria. Fine. Okay. So this class C is acting on atria, ventricles, and Purkinje fibers. It means entire heart, right? Flecainide and propafenol. These are like, because they are so powerful, because of their extreme power, they can cause arrhythmias, right? So to be used with extreme care, they can give metabolic taste, metallic taste, and treatment of ventricular tachycardia, but we are trying to remember this. Refractory arrhythmias. We require power only when things are really in not responding to anyone. So because this class C is so powerful and nothing is working, that is refractory. Refractory means it is not responding. It is at that point we say, okay, now 1C, it's your time, right? Push this truck and they will take over. So that's how we are dealing with, say, class 1 of antiarrhythmic drugs. Let's start with the class 2. Now in class 2, first some of the basics, right? In this our basics, there is ANS, autonomic nervous system. Autonomic nervous system, it is acting on entire body. We know that there is parasympathetic, there are sympathetic, right? And then there are specific neurotransmitters, there are specific receptors. Everything, this would be our prime concern in our second series, where we'll be starting from this point only, where we'll be going into the depth of every receptor so that you know that why it happens that whenever there is a sympathetic supply, right, whenever there is sympathetic situation, that is when sympathetic nervous system is into action, few muscles dilate, few muscles contract. Why it happens, right? Why in sympathetic system it's like eyes are wide open. Why it happens? And why it happens that all those urinary sphincters, they are tightly closed? Why there is no peristalsis? Why it happens that some are contracting, some are not contracting? That's what we'll see in depth for the full body. So the moment you would talk about that, okay, we are dealing with, say, alpha receptors, or we are dealing with beta receptors, or we are dealing with beta 1, beta 2, all those things would be completely solved. So that then when you'll say that we are using a selective drug, selective means your next question would be, okay, on beta 1 or beta 2, right? Or its advantage would be when you are using a non-selective drug, it means you are trying to handle the bronchospasm, but that drug is acting on other areas also. But when you become selective, you are pinpoint targeting the drug that only go to that bronchus, relax it, and don't go anywhere and don't talk to anyone else. This is where you become selective, right? So that's the importance. Today, because we are dealing with just heart, that's why we are restricting ourselves to only the adrenergic receptors. In adrenergic, there is beta 1 and beta 2. And beta 1, they are specific into heart only. And in heart, they are present in pacers, our pacers, and runners. That is our SA node, AV node, and our myocytes. But these are acting on phase 4 and phase 2. What's this? What's this? See, these beta receptors, right, there is a complete mechanism, right? But over here, the phase 4, right, these are our pacers. Just remember that beta 1, when we stimulate beta 1, they'll be slowing down this part, first part, that is that, where it would take time to reach to that threshold potential, right? If it is taking more time to reach to threshold potential, that firing would be slowed down, right? Because it is taking more time. And over here, in case of our runners, that is our myocytes, this is the phase of that plateau. Plateau means we know that this is the phase of contraction. So if that thing is slowed down, it means the contraction would be not like this, it will be like this, right? It will be slowed down. So here, this is the difference, that what would this beta 1 do when on pacers and myocytes when it is activated. By the way, this beta 2, it is into smooth muscles in blood vessels, right? In blood vessels, there are smooth muscles, so they'll be leading for those vasoconstriction and vasorelaxation part of thing. Here it is, class 2, which is like beta blocker. It prevents binding of epinephrine and norepinephrine, right? These are the neurotransmitters which will be working on that. So over here, Some are selective, some are non-selective. Selective means we said that they work only on beta 1. Right? And non-selective, it works on beta 1 and beta 2 both. All these atenolol, acebutolol, betaxolol, esmolol, metoprolol, ending with olol, right? Olol. So here in non-selective, it would be timolol, propranolol. So that's how the non-selective. So just remember one or two names initially, and then later on you can keep it. So remember etilol, acetobutol, esmolol, metoprolol, right? That much is sufficient. More as we proceed. Here, timolol, propranolol, they are non-selective. So they act by what exactly they do. See, there is a complete mechanism, but over here they act by calcium entering cell. That is prevented. Now the things are clear, right? So easy. What it is doing? Phase 4 in pacers. That is right from the beginning. Those calcium which was entering, right, and which was triggering, that thing is stopped. So result, decreased heart rate and decreased conduction velocity at AV node. This I am interested in. It decreases conduction velocity at AV node, right? AV node. As such, what was AV node? From SA node to AV node. AV node is the only junction which is telling that from atria to ventricle when you want to go, right? From atria to ventricle you want to go. That's the only window via which it will pass. Otherwise, there is no other path. What if this is slowed down, right? And if it is slowed down, then the trouble is there is no way you can enter into ventricles. It means it's a block. It's a block, right? So that's why take care of it. And do remember right now this point that this beta blocker, they decrease conduction velocity at AV node. Okay, all right. Say in phase 2 in myocytes, right, contraction phase, plateau is affected, weak contraction of the heart, and that would decrease oxygen requirement. So things are good, right? Where it is used? Supraventricular tachycardia, right? Atrial fibrillation, flutter, post-MI prophylaxis, all those areas where we really want to tell the heart, calm down, right? That's what we really want to say. Adverse effects, there are cardiac and non-cardiac. Cardiac, see, it is slowing the heart. So bradycardia will not say the adverse effect, but when it is so much that it can lead to heart block and heart failure. That means if the dose increases, it is this AV node. If it is shut, it can lead to heart block, right? The non-cardiac, things are slowing down, right? Literally, things are slowing down, so it will be like a sedation, right? It is like a fatigue. And when it is like sleep is not proper, sexual dysfunction, right? Difficulty in breathing, right? Bronchospasm. Why bronchospasm? Bronchospasm, this is in non-selective because see, it is blocking beta 1 and beta 2 both, right? Beta 1 is in heart, so that's fine. But this beta 2, that is in lungs. And we gave a drug and we said, okay, all betas down. So the heart though has slowed down, heart is happy, but then in lungs, these beta 2 receptors are there. Even they are blocked. So that will lead to this bronchospasm, right? See what really happens. Had we be giving beta 1 selective, lungs are not affected, but now the lungs are affected. So that's what it really happens. One of the very important thing which is called as hypoglycemia unawareness. When the patient is hypoglycemic, he feels tachycardia, palpitation, tremors. When such things are not felt, it is called as hypoglycemia unawareness. That's the reason this class 2 should not be mixed with class 4 calcium blockers, calcium channel blockers. Because if you are giving this is the beta blocker. And then on top of it, you are giving calcium blocker also. This is like they will be decreasing the conduction in your pacers, AV block especially. And if this AV is affected, right, AV node is affected, it leads to AV block. And when the AV block is there, there is no way anything can go to ventricles. Dangerous. There are contraindications, pheochromocytoma, cocaine toxicity, but relax on that, right? Say, because what they can do is vasoconstriction, and then there is, because of that, increased blood pressure and can lead to aortic dissection. But well, all these things, they are not that vital right now. Just understand the mechanism. Later on, we'll add all those extra points. Moving on to the class 3, this would be super easy. Reason, potassium, right? Potassium is affected. So potassium channels are blocked. So over here, in case of myocytes, it is the repolarization phase, right? Repolarization phase. So potassiums, they are going slow. So that fall, that will become gradual, right? That fall, which was like this, now it would be like this, right? So that's the difference, because now here potassium channels, right? They are affected. So slow potassium channels, right? So slower repolarization, prolonged effective refractory period. Yeah, that's what we were even say working on. That's the refractory period. That refractory period is elongated, and there would be larger QT and heart rate would be decreased. So ventricular tachycardia, fibrillation, flutter, that's where it is used. But the thing is, this amiodarone, this is so powerful, it acts on sodium, potassium, beta blocker, and the calcium. It acts on everyone. See, sodium, right? Class A, class 1, beta blocker, class 2, calcium blocker, class 4, and in class 3, so it is already there. It blocks everyone, and it has got long half-life of 20 to 100 days. It means once given, it will keep on acting on and on. 100 days means half-life is by what time its efficiency is reduced to 50%, right? So that's why it is used less, because toxicity. It is what is called as the lipophilic. It stays. And philic means loving. Lipo means it is fat. So it is fat loving. So it binds. It stays and keeps on acting, right? So that way its toxicity rises. And when such thing is given, you have to take care of lung and liver, because it can lead to fibrosis and liver dysfunction. And obviously it can lead to heart block. Right? The better drug is drondaron, right? Drondaron. Similar to amiodarone, the biggest advantage is shorter half-life, 24 hours. That is good. So it is used in atrial fibrillation and flutter, not used in ventricular tachycardia, right? Because over there you have to give it for longer duration. So it is used short half-life, so it is for atrial fibrillation, flutter. Side effects, GI, right? Nausea, vomiting, diarrhea. Always when you make notes, right, make something like this, that when you write GI and NVD, that means it is gastrointestinal effects, nausea, vomiting, diarrhea, but that is sufficient. Why to spend more time in writing all the way those lengthy things? So we talked about this amiodarone, long life, drondaron, right, shorter life. And then we have got sotalol. This sotalol is non-selective. It means it is going to act on everyone, right? When it is going to act on everyone, so there will be all those side effects like bradycardia, hypotension, right? And finally, these two, they are like abutylide and dofetilide. There is only one difference. This is given IV, so in case of acute, and this is oral, so for the long term. For what purpose? Atrial fibrillation. right? Regarding this torsa point, this is once again a condition, right? It is a very dangerous condition, but again, we'll be learning it in cardiology, right? When we'll be going in depth about cardiology. And finally, we have got, say, these calcium channel blockers. So this is class 4, right? Calcium channel blockers, two types. Dihydropyridines, dihydropyridines, and second is non-dihydropyridines. We are dealing with this, right? So that's why we are not writing it here, but we are writing it here. So calcium channel blockers, that means they are used for some other purpose also. Yes, the purpose is hypertension. For blood pressure also, you must have noticed that some of the drugs, their name, they are quite even known to you. Amlodipine, many a times you must have used that, it is given to those patients, right? This nicardipine, nifedipine, right? These are some very standard drugs for hypertension, right? Because they are acting on smooth muscles of vessels. So vasoconstriction and vasodilatation, that's how you actually control the load into the system. Because see, things are so easy. This is your container, and if it is filled with fluid, now fluid volume is it can also be changed. But if you want to decrease the pressure, right, what if you make it like this, right? So now same amount of fluid is into this container, but the pressure exerting it on the walls, that has decreased because now there is more space, right? Vasodilatation, right? That's how the things are. And over here, class 4, and here comes our known candidate verapamil, right? We talked about this verapamil. So that verapamil, right, it is the non-dihydropyridine calcium channel blocker. So where it acts? For pacers, because it is calcium channel blocker, blocks the calcium. In case phase 4 and phase 0, that's where the calcium, these are the pacers, right? For pacers, those SCN was coming up. So prolonged effective refractory period, decreased heart rate, that's where it is acting. Decreased conduction velocity on AV node, and yes, that's the reason we'll remember that this was the point, that because it is acting on AV node, we should be very careful when, in fact, it should not be done, right? Mixing it with beta blocker, right? We should not be using it with beta blocker. Well, on myocyte, it is affecting plateau. Plateau means that is the phase, now you know it so well, that it is the phase where the contraction is occurring. It will lead to weak contraction, right? Weak contraction. Okay. Verapamil, selective for cardiac calcium channels. So used for angina pectoris, that is when the pain is there, but it is reversible. But well, it is like a initial state. Tomorrow we'll be talking about it. That is the pre-MI conditions and the post-MI management. Then supraventricular tachycardia, atrial fibrillation, flutter. In fact, tomorrow, yes, there would be some good discussion on these topics also. The second one is diltiazem, cardiac and vascular channels. Vascular, right? That was pure cardiac. So that's the reason we'll be using it in hypertension and SVT. And that's what we say. Do not use with beta blocker class 2, right? Side effects are constipation, flushing, heart block. We are dealing with right now, we are talking about heart block. Why constipation, flushing? Well, because it is the beta blocker. So this was about all those cardiac arrhythmic drugs. Now, what will you do is say, yeah, just remember this miscellaneous, our specials, right? So our specials are adenosine. It is given intravenously, right? It is easy. It has got onset 20 seconds and duration of action 10 seconds. So it is very short acting. It acts on very specific, very special receptors, subtype 1. They are into pacers only. So what will do? It will open those calcium channels, right? So decrease calcium, and this is the decreased conduction. Same supraventricular tachycardia affecting L type, and then the digoxin, right, decreased heart rate, decreased conduction velocity, and it is short acting. So side effects like arrhythmias and tachycardia and AV block. See, do it like this. The other one is magnesium sulfate and magnesium chloride, and in the treatment of arrhythmias and digoxin toxicity. See, now do it like this. Make a note like this. Class 1, right? This is the one page which you should prepare. Just one page. Class 1. So don't write class. Just write write 1 and then alpha. Strike it. So this is sodium channel blocker. And in this you write A, B and C. Correct? In A, over here make it 3. So this is most powerful. Here make it 2. This is moderate, and make it like this. So this is the weakest. Then in 1 we remembered that queen. So quinidine. And then we visited Egypt. So that was diisopyramid. Correct? But there was one more. So be professional. Procainamide. Right? Procainamide. In case of that class B, we remembered that lidocaine, which was local anesthetic, and that's why it was very important. And then McDonald, right, which was having that GIT symptoms, GIT side effects, maxilitine. In class C, it was easy. Propranolol and flecainamide. But regarding this, right, they are used less because they are extremely powerful. In class 2, beta blocker. Just do selective and non-selective. In case of selective, all those, right? Atenolol, acetabutalol, right? Then esnolol, all olol, right? Metoprolol, all olol. And then non-selective, timolol, right? It is a team. It is acting on everyone. So timolol, propranolol. Then it was 3. 3 was what? Potassium, right? And in potassium, amiodarone, dranodrone. These were the main, right? There was one more, sotalol, right? There were others, but this much should be sufficient. And then finally the 4th, this was what? Calcium channel blockers, right? In that we do have that dihydro and non-dihydropyrimidines. So over here, these are used for hypertension, right? They are used for hypertension, in which there was amlodipine, nifedipine, right? That is sufficient. And in non-hydro, we never forget that verapamil, right? So verapamil. And then diltiazem. And then finally those specials. In special, we'll just remember one, that is digoxin, right? And then there was magnesium sulfate and magnesium chloride, and we were having adenosine. this page, you write it down like this and stick it on the wall. Keep watching it for 2-3 days, and then try to write it down. Write it without watching. Do it once, do it twice, do it thrice, and don't miss to see this page. These are your sleeping hours. Just before you go to sleep, have a look at it. Next morning when you wake up, just have a look at it. Gradually, as we'll be studying more and more pharmacology, it is about, there would be at the most 25 such pages. Slowly and gradually, these pages, they will go into your photographic memory. And into this only, you'll start adding more and more those extra characteristic of every drug. In this only, right? So, obviously, if someone else would see this paper, they'll say that, okay, this is crazy, right? But you don't have to remember that the moment you say, okay, queen, right? So you will just do like this much is sufficient for you. You'll know that this gives that blurry vision, right? This gives that tinnitus in the eyes, and then it can give headache, right? This much, it has saved so much. And this is what pyramid was like Egypt. You just draw this thing, but enough. Now you know that this is what gives dryness to the mouth. It will decrease lacrimation in the eyes, right? It will lead to urinary retention, and it will lead to hypotension, right? This makes, yes. You just write GI, but it is enough. It will give nausea, vomiting, diarrhea, right? So that's how, as you remember more, you just add those symbols. Try to add those symbols. Never ever write all those lengthy things, right? You are bound to forget it. But when you do it like this, you'll find it very interesting and much easier. After few days, you'll find that that entire piece of paper, it will become part of your memory, right? So that's it for, say, today, and we shall meet tomorrow, right? And there we'll be discussing the myocardial infarction. Now in myocardial infarction, it would be the combination of everything whatsoever we have learned in, yeah, that's what we summarize. Yeah, but at the end, that is tomorrow, in the myocardial infarction, it would be a combination of everything what we learned from day 1 to day 9, right? Where the anatomy will come into picture, where the physiology will come into picture, where the lifestyle will come into picture, then there will be conduction mechanisms, all those medicines, everything, because we'll be taking it as if it is a medicine class, right? Now, you don't have to worry about whether you are in first year or second year. That's okay. You can definitely understand, because now you have got the complete foundation ready to understand myocardial infarction. All right. Thank you so much. And we meet tomorrow at the same time. Thank you.